Thank you for the opportunity of a second talk. Our institution acquired a unit on digital spyglass a few years ago, and we were told that we were the first group in Asia to acquire such a unit. This is an interesting device. You can see at the tip of the scope you have two CCDs. It's really a plug-and-play device, and it auto-focuses itself. And there are a number of very nice features, including an aspiration channel. So it is an improvement from the older version of the spyglass. I thought I would share with you some of our experiences. So we use digital spy for a few purposes, mostly for evaluation of bile duct strictures and on imaging filling defects within the bile ducts. We also use it to manage difficult bile duct stones, and we've used it for other indications such as management of trapped basket with stones and so on. So I just like to show you some cases and then review the literature with you on the potential uses of digital spy. Please play the video. This is a case of mid-bile duct stricture, and it belonged to a 75-year-old man, and you can see for some of the so-called indeterminate stricture, and that the spy appearances in fact produces very characteristic features of neoplastic stricture. And this is very typical fish scale appearance, and the other feature is the clonochus that you see, very common in China, southern China and Hong Kong. That is clonochus infestation associated with cholangiocarcinoma, and that you can see very neovascularizations that are typical of neoplastic strictures. Things are not so easy. This is, play the video please for me. This is a different case. This is a young man with, again, a mid-bile duct stricture. And this young man actually came to us for evaluation, and at the far end you can see the bifurcation, and that the appearance is abnormal, but it's not typical of a malignant stricture, and that you can see a lot of scarring. You do see, this is the left duct, and you do see abnormal vessels, but then these are not very typical of the neoplastic vessels that we see. This was on biopsy and on IgG4 staining proved to be autoimmune cholangiopathy, and the patient responded to the use of steroid and avoiding a Whipple's procedure. This is another case of a young woman. Please play the video for me. This is a case of another young woman. She has chronic relapsing lymphoma. She's been diagnosed for 9 years, and she came back suddenly with a mid-bile duct stricture and jaundice. I think the management decision was whether she had a second malignancy or whether this was part of her lymphoma disease, and we put an cholangioscope in, and the cholangioscopic picture is sometimes very difficult because you can see also abnormal vessels, and there are some nodular appearances. And we went on to biopsy this patient, and the biopsy showed a lot of abnormal lymphocytes consistent of a disseminated lymphoma disease. And she went on to receive chemotherapy, and in this particular case, we also, the patient avoided Whipple's procedure. And as I said earlier, and you also see vessels that are slightly dilated. So it's really quite difficult to differentiate sometimes, particularly after a period of stenting. So play the video, please. And this is a case where we use the spyscope for evaluation. This is actually a digital video scope. In our locality, we see a lot of recurrent pyogenic cholangitis, and sometimes we asked to evaluate intraduct strictures, and cholangiocarcinomas actually happen in 10 to 20% of patients recurrent pyogenic cholangitis. And this is at the origin of left duct, and you can see all this fish scale appearance, but on biopsy, this was actually not non-neoplastic, and in this patient, he avoided a left hepatectomy. This is not my video, but I guess in the Western Caucasians, amongst the Caucasians, you do see pyogenic, instead of pyogenic cholangitis, you see primary sclerosing cholangitis, and often you see intrahepatic duct strictures. And again, this device is useful for evaluation of strictures and for possible biopsy or tissue sampling before hepatic resections. And again, this was proven to be benign lesions. Having seen all these cases, the literature to support the use of spy scope in some of these conditions are not actually very convincing. And this was a series published by the Karolinska group on evaluation of primary sclerosing cholangitis with the use of POC. The technical success rate was high, and they were able to sample strictures with cytology and biopsies in a high proportion of the cases. But in that series of 47 patients, they had 3 cholangiocarcinoma. 1 was diagnosed with POC, and all 3 patients underwent 3OC, and the other 2, the diagnosis was missed. 1 was at segment 2, and that the patient developed a mass 17 months later. And 1 was at a Hyla, diagnosed only at liver transplantation for recurrent sepsis. The sensitivity of POC in primary sclerosing cholangitis was only about 33%. There have been efforts to come to a nomenclature in describing all this vascular pattern, and this is a paper published by Itoi. So he had a handful of patients, and using video cholangioscope, we describe all these changes, type 1, 2, and 3. The ones are these tiny vessels characteristic of inflammatory or benign strictures, and the type 3s are characteristic of neoplastic or cholangiocarcinomas, and the type 2 are the in-between. So he had a small number of patients, but what he found was the partially enlarged vessels or the type 3 vascular pattern would be very diagnostic of a distal cholangiocarcinoma not seen in other conditions such as IgG4 cholangiopathy. Also the dilated vessels are more seen in cholangiocarcinoma except the Hyla cholangioles. So he had a small handful of patients, and he came to this nomenclature. Unfortunately, the spy scope has been around for a short time, and we really do not have enough experience, and that the nomenclature has yet to be validated. I think at the time being, we still could continue to rely on other features such as clinical features, and we continue to rely on the use of biopsy. And in the case of the diagnosing IgG4 disease, we need biopsy and IgG4 staining and histology. So the University of Florida group performed this meta-analysis over the use of single-operator POC in the evaluation of bile duct strictures. And the group actually pulled all the studies together, and admittedly, some of the studies included the earlier generation spy scope that use optical fibers. But I think the message to come away with this poor analysis is that the sensitivity in diagnosing malignant stricture using POC is in fact not that good, 61%. But when you do get an adequate biopsy with a diagnosis, the specificity approaches 100%. So if you get a positive diagnosis, the diagnosis is firm. If you do not get a diagnosis, it really doesn't mean that the bile duct stricture is non-neoplastic. The Dr. Varadarajulo from Florida, please play the video, actually came to the use of rapid on-site histology to improve the diagnostic sensitivity. This is his video showing a very typical cholangiocarcinoma with all these dilated tortuous vessel and some very thickened. And so he went on to biopsy, and that instead of straight away sending it to the pathologist, he would then do what he called on-site rapid evaluation by smearing the biopsy specimen onto a glass slide and fixing it with alcohol and staining it with methylene blue, and looking down the microscope to ensure adequate cellularity. And this is what they would do. And I suspect it would be better to have an on-site pathologist to tell you that you do get an adequate sample and that it is suggestive of a certain diagnosis. The use of spicroscope is often quite useful in looking at some filling defects. A case referred from outside hospitals with multiple filling defects within both intrahepatic ducts and secular dilatation of the intrahepatic ducts. And this is the MR. There were a number of diagnoses being put forward, such as sclerosing cholangitis, kind of atypical coronary disease, and so on. And we put it in an endoscope, and when we injected contrast, the contrast wouldn't go up to intrahepatic duct. And this is what we saw of a spicroscope. We are actually at the hilum with multiple calculi, and this is a case of recurrent pyogenic cholangitis in a young patient with numerous calculi packing both intrahepatic ducts. And this patient, without treatment, would slowly go on to a form of cirrhosis, and that we went on to treat the patients with endoscopic means. Another case, grossly dilated bile ducts. You get the CT on the right side. You can see filling defects within the right intrahepatic duct. This is, we put the scope in, straight away we saw a lot of mucus and a fish mouth appearance of the papilla, and by putting the scope into the right intrahepatic duct, we see a lot of villous projection, and this is a case of intraduct papillary neoplasm of the bile duct. And the use of a scope can, in fact, evaluate the extent of this tumor involvement, and in some ways can guide the extent of the excision. In this particular patient, the changes were confined to the right intrahepatic ducts, and unfortunately, this patient declined surgery. Should we use the spicroscope all the time? The answer is probably not. There's no universally agreed definition of indeterminate bile duct stricture, but most people would accept a bile duct stricture without a mass in cross-sectional images as a definition of indeterminate bile duct stricture. This is a case series from Adelaide that they were referred difficult bile duct stricture before, and that they use a EUS first approach, and I think this is actually quite a reasonable approach, and in about 75% of the cases they were able to obtain tissue and obtain a diagnosis with EUS alone in 58% of the cases. In many cases that a mass was not seen in cross-sectional images, and they were able to see, and that subsequent POC was needed only 19 patients, successful in 18 patients. There were 7 lesions thought to be inflammatory, and 2 of them subsequently underwent surgery, and they both were confirmed to be cancers. So a negative POC or inflammatory diagnosis on a POC does not, in fact, exclude the diagnosis of a cancer. So moving on to stone therapy, the usual indications are we often get referrals from patients with after failed basket mechanical lithotripsy because of the size and more often because of a calculus impaction, and some of them belong to the Mirici type 2 syndrome. This was one of the patients referred to me. If you measure the stone size, it was measured to be 5 centimeter. This was treated by POC, and one can imagine that a BML basket would be difficult to go around the stone itself. This was a young patient referred from China and had a stone impacted at the junction of cystic duct and common hepatic duct. And you can see a pouch of the Hartmann pouch on the completion cholangiogram, and the difficulty was getting a basket around it because part of the stone is in the Hartmann pouch of the gallbladder. And to me, this will represent a Mirici type 2 syndrome. This is one such case. You can see, please play the video. And this is a case with a stone impacted at the conference of the cystic duct and the common hepatic duct. You can see just on the plain film, the stone does not really move. So the spyglass was used, and we used a holmium yak laser. And in this, you can see towards the right-hand side, you can see bile coming through the cystic duct opening. The stone actually fissurated through this Hartmann pouch and eroded into the common hepatic duct. And we used a holmium yak laser to fragment the stone. And why holmium yak laser? Because we bought the units. There are units that use EHL. I think it probably work equally well, except the use of EHL. You really need a lot of fluid, and with the laser, you don't need to put in as much fluid. After fragmenting the stone, the stone became more mobile, and they were able to complete the procedure using a BML. We'll just show you a little bit of the video, and that we were able to clear the bile duct in one setting. So this is not a video, this is a video by Dr. Cunningham, and this is kind of the same video to illustrate Mirici type 2 syndrome. And you can see the cystic duct opening, and in the middle there's a septum, and the stone in fact eroded through the Hartmann pouch of the gallbladder into the common hepatic duct, and this is a type 2 Mirici syndrome. It's often very difficult to get a basket around it because of the eccentric nature of the stone, a big part of it being in the Hartmann pouch of the gallbladder. We wrote this some years back when we first acquired the spyglass, and we reported our early experience in 17 patients, and we were able to clear, in 16 patients, we were able to clear the stone with a median of single session, and there were 2 patients without cholangitis. I'm sure there will be further reports confirming that the spy scope is in fact quite useful in the management of difficult bile duct stones. The only randomized control studies that I can find came from the University of Southern California group, where they randomized patients with bile duct stone greater than 1 centimeter in size. They randomized patients in a 1:2 ratio, more patients in the laser group. The statistical difference was in the complete stone clearance being higher with the use of laser, 93% consistent with our earlier reports. And in the conventional therapy group, only 2/3 of the patients' stone clearance was successful. And that the use of laser, more sessions were required. And that the only other difference being the conventional group, more papillary dilation was used, and there were more basket impaction needing rescue lithotripsy. There was really no major difference in other outcomes. I think this only RCT confirms that POC guided laser therapy in bile duct stones is associated with higher stone clearance rates. And with this, I end my presentation, and thank you very much.
Thank you very much. So nobody can argue that endoscopists are awesome people. We're 10 minutes ahead of time, so I'll ask Dr. Ahmed to come over and Professor James Lau, and we'll take a few questions from the audience if there's any questions, comments.
Thank you, Professor. It was nice to see a surgeon doing endoscopy. My question is the following. You injected first in the bleeding DU, and then you applied the clip. Anatomically, the duodenum have got layers. When you inject, usually you will lift the submucosa away from the vessel. So what you did actually was just to close the crater of the volcano. Perhaps you would get part of the vessel as well. Thank you very much.
Well, I don't routinely inject into the base of an artery, only if I find it's difficult to, in fact, to put the clips in onto the base of the vessels, and I sometimes inject. So I don't do it as a rule, but I think that case illustrates nicely. If you inject it, you elevate a little bit of tissue, you can actually have a firm grip of the base to the vessel.
Dr. Sajjad Mahmood, I'm a consultant gastroenterologist based here in Riyadh. My question is to Dr. Ahmed. I've seen that we give up on patients who come in with acute pancreatitis too early and label them idiopathic very early. I don't think they're investigated well enough. Is there something you've seen as well in your experience?
Thank you for your question. Actually, this was one of the main goals that I wanted to present today at this talk, is that we should not be ignoring these patients who present with recurrent acute pancreatitis, as we have seen from our own local experience, plus the evidence from the studies that these patients can go on and progress to chronic pancreatitis. So the earlier they get referred, the better the outcome is, and they can be referred to centers with advanced endoscopy service. I hope this answers your question.
Thank you very much. I agree with you. I think we can't really label idiopathic unless we rule biliary sludge with US or pancreatitism, and especially. Just one more question, if I have time. Your experience on metal stents for pancreatic strictures? You think these are useful only in the head, or can you go further higher up in distal body?
Usually it can be used at the head and body only, but if the stricture is at the tail, you can try plastic stenting, but we have good evidence to support the poor outcome of endoscopic therapy with distal strictures or stones. So we're not excluding endoscopic attempts. However, again, this should be discussed at a multidisciplinary fashion with the rest of the team, and every case should be individualized and approached accordingly.
Thank you. And what do you do for pain management, especially post-metal stents? Some patients do not tolerate it very well and excruciating pain for the first 48 hours. So what do you do?
They can get narcotics. If it's just a stricture dilation related effect from the metal stents, usually this will be transient. However, if they do have more advanced disease, they will be on narcotics anyhow to start with. We leave, if that was your question, for the celiac plexus block only for cases who fails narcotic therapy and endoscopic therapy for stent and stricture management.
Thank you. Use PCA much for this?
I think you have to give a chance for other people to ask. Please.
Yes. Enjoyed the two endoscopic talks immensely. Thank you very much. My question to Professor Lau, what is the role of spyglass in anastomotic biliary stricture following liver transplant?
Prof, excuse me, before you proceed for questions, we receive a lot of questions regarding the indications of spyglass and biliary stricture. Do you have to do spyglass for every patient or at certain cases or?
Thank you for your question. As I alluded in my talk, we do not have a universally accepted definition of indeterminate strictures. If on cross-sectional imaging you see a mass, usually the investigation to follow is EUS. So EUS, you try to needle lesions, and even in reported indeterminate strictures, often when you perform EUS, you can see sometimes thickening of the bile duct, for instance, and then you can then go on to fine needle aspirate and before subjecting the patient to POC. So we don't do POC in every single patient. So in fact, POC is a little limited, only after a negative EUS. Going back to your earlier questions, anastomotic stricture, I think if there's a concern that there's a recurrence, for instance, for actually evaluation of neoplasm, I don't think it itself has a therapeutic role as such. So I hope I have answered your question.
Do we have another question from the audience asking about the evidence of celiac plexus in chronic pancreatitis? So usually it's indicated in pancreatic cancer. So what about the chronic pancreatitis?
There is a difference between celiac plexus neurolysis and celiac plexus block. The best evidence we have is for neurolysis, which is semi-permanent damage for the nerves with the injection of alcohol, and these are reserved to patients with chronic pancreatitis and are a well-established indication. However, for chronic pancreatitis, the steroids are used for celiac plexus block because it has less risks of complications. The evidence, again, we can debate this for a long time, as we have mentioned. The data are heterogeneous. We have seen from the meta-analysis presented that up to 60% of patients do respond. However, they only respond for a maximum of 6 months. And once you started, you have to be ready, and patient has to be ready for repeated interventions.
So with that, we conclude this session, and thank you very much for attending. We'll have a coffee break, and we'll be back here at 3:30, inshallah.